since we had any meeting under the aegis of US. Now also we wanted to have a live meeting, but because of the changing scenario, we couldn't have one. So we thought of having a webinar. Today we are talking regarding neovascular AMD. We all know that it's quite a challenging disease, and with the recent advance and new injection coming up in the market, it becomes confusing what to do, when to shift to other drugs, and what to try next for the patient. And recently, we have been introduced with a newer drug from Novartis, brolucizumab, and today we will be having a good overview regarding the same. I wanted to introduce our speakers. First of all, we have Dr. Venkatramani, a fellow from L.V. Prasad Eye Institute. He is currently working in Lakshmi Eye Hospital, Mumbai. We welcome you, sir. We have Dr. Anshu Arora. He is still to join. He is a fellow from Shankar Nethralaya and is currently working as a senior consultant in Eye Care Hospital in Noida. In our panelist, we have Dr. Ankit Punjabi, Chief Vitreoretinal Surgeon from Kota Eye Hospital and a very dear friend. He's a fellow from Chennai, and he's currently working as a VR surgeon in his own setup. Then we have Dr. Arvind Jain. He is from Alaknand Eye Hospital, Udaipur, and he is a chief VR surgeon, and he's been working since last 1 year in Alaknand Mandir. We also have Dr. Rohit Yogi. He's a past fellow from L.V. Prasad Eye Institute, and he's currently working in ASG Eye Hospital in Udaipur. So I welcome all of you, sir. And we'll be having 3 talks today. First of all, I'll be speaking on unmet needs in wet AMD. I am Dr. Karthikeya from Dr. Kothai's Eye Hospital, Udaipur. I am a vitreoretinal surgeon working in Udaipur itself. Then we'll be having Dr. Devinder speaking on Hawk and Harrier, part of the brolucizumab. And then the third talk will be taken up by Dr. Anshu Arora on his experience on brolucizumab. So we can have any queries or discussion in between the talks, or we can take it after all the talks are over. Regarding audience, if they want to put any question, they can type there, and we'll be taking them in afterwards. Without taking much time, I'll start with my talk. Good evening, everyone. I'll be speaking on unmet needs in management of neovascular AMD. I'll be covering it under the following headings: the need for effective therapies in neovascular AMD, the extent of the problem, continuing decline in vision in real-world clinical practice, burden to the healthcare system, and burden to the patient as well. So, coming to the need for the effective therapies in neovascular AMD. As we all know, AMD is a leading cause of severe and irreversible vision loss worldwide, accounting to around 10 to 13% of adult population over 65 years of age, making it #1 cause of blindness in developed countries. There have been increased prevalence, and it is thought to be around 8.7% of contributing to 8.7% of total blindness worldwide, and it is a consequence of aging population. The aging population is increasing because of modern facilities and modern healthcare facilities, and it is estimated that it will be reaching around 196 million in 2020. Of course, majority of the vision loss occurs in the neovascular AMD, which contributes to around 15% of total AMD cases. Worldwide, it has been predicted to be around 8.7% of total cases of blindness, whereas in developed countries, it is becoming one of the leading cause of blindness. In European countries, it accounts to around 50% of all those total cases. So research have focused on providing effective therapies in neovascular AMD. In pre-1980s, when there was no treatment, there used to be rapid progression with vision loss. Once thermal laser came into part, they used to cause a lot of retinal scarring and recurrent neovascularization. In early 2000, we had photodynamic therapy, and which used to slow down the progression of vision loss, but actually there was no visual improvement in majority of the patients. And once anti-VEGF came into play since 2005, there have been transformational visual and anatomical outcomes. Anti-VEGF therapy has reduced the incidence of AMD-associated blindness, and it has been seen that there have been around 50% reduction in incidence of AMD-associated legal blindness. Currently, the anti-VEGF monotherapy is the gold standard treatment for treating neovascular AMD. It has dramatically reduced the incidence of blindness and severe vision loss. However, in real-world setting, patients with neovascular AMD may not achieve the best possible long-term outcomes. And so still there is unmet medical need which still exists. Despite improved outcomes, new treatment options are still required to address these unmet needs. Regarding the extent of the problem, it is becoming a global burden, as the global prevalence was predicted to reach around 196 million by 2020 and is estimated to reach around 288 million by 2040. Majority of the cases have been, as depicted in the graph, are in Asia and will be increasing. And Asia seems to be leading all the other continents. And this will again, in turn, make the burden of care in neovascular AMD even greater. The increase in prevalence is set against cost and that are already high, as we all know, and especially in developing countries like ours, cost is a big factor, which so increasing prevalence coupled with high resource utilization is extremely difficult for healthcare systems to manage. There is continuing decline in the vision in real world clinical practice. So there's a lot of difference which exists between the clinical trials and what actually we follow in our private practice. Even the results vary, because in clinical trials, patients are kept on regular injections, they are kept on regular monitoring, but that actually is not possible in real practice. And that's why clinical trial regimens are difficult to achieve in real world clinical practice. Long-term visual acuity maintenance in clinical practice is related to treatment intensity. So anti-VEGF treatment in clinical trial setting demonstrate good efficacy, but the burden in real clinical world practice limits similar uses. Use of anti-VEGFs in clinical trial maintains good visual acuity, whereas lower treatment frequencies can lead to visual acuity decrease over time. So compared with clinical trials, long-term visual acuity improvement may not be maintained in real world and are associated with fewer treatments. There are a lot of compliance issues which we face every time in with patients. Regular follow-up visit comes to play. Patients are always, many patients are unsatisfied. Not be practically possible in clinical practice. So in real world clinical situation, vision continues to decline in neovascular AMD patients, and this is linked to the frequency of treatment monitoring. Like you need the visual acuity maintenance as well as efficacy in visual acuity improvement. It depends a lot on your injection intensity and regular monitoring. So it's a burden to the healthcare system, and as there's always, the vision is always declining, there are limited treatment choices. You need to monitor the patient regularly. The drug cost is high, and the prevalence is increasing because of longer patient lifespan. So some of these factors have led doctors to explore different regimens for anti-VEGF therapy. Unmet needs regarding the doctor's perspective, they still identify treatment and monitoring burden as key unmet need in neovascular AMD management. Indeed, monitoring visits are the most time and resource consuming part of patient care with anti-VEGF therapy for individuals with neovascular AMD. on so the treatment monitoring burden can lead to undertreatment. Physicians have increasingly adopted flexible regimen, particularly treat and extend, to increase individualization and reduce the burden on healthcare sources. However, this may result in delay in detection of recurrences and suboptimal treatment frequency. So, it is not possible to predict disease reactivation when extending treatment intervals. Sometimes we do treat and extend, but in clinical trials, patients are generally stable, but lengthening the intervals and not following the patient in between can sometimes lead to reactivation of the disease. And sometimes there is exacerbation of the subretinal fluid, or the membrane becomes aggressively active. And then again, we have to start with the same regimen, and then it might take longer time to treat. So it's a burden to the patient as well. And on the patient part, the frequency, treatment and monitoring requirements place a heavy burden on the patient. They have cost burden, they have transportation issues, it is time consuming. Sometimes the hospital is very far from their home. And patients, the most important is they are not satisfied with the benefit of the treatment, as because what we aim is to stabilize the vision, and what they expect is with such heavy cost of injections, they want improvement in vision acuity, which sometimes is not possible. So, and there's a burden of follow-up visit. Patients' quality of life gets affected. They are preoccupied by their frequent clinic visits. So, despite AMD being a chronic disease, demand of treatment regimen cause patient to discontinue anti-VEGF therapy. And distance between home and hospital and dissatisfaction with the treatment and the need for regular follow-up visit are cited as the main reason for stopping the treatment. So due to frequent injection, patients undergo treatment fatigue with VEGF therapies, and some opt to discontinue the treatment. So to summarize, the increasing prevalence coupled with high resource utilization is extremely difficult for healthcare system to manage. In real-world clinical situation, vision continues to decline in neovascular AMD patients, and this is linked to the underutilization of treatment and monitoring. Doctors identify reducing the treatment and monitoring burden and development of treatment with increased duration of efficacy as key unmet needs. Patients undergo treatment fatigue with anti-VEGF therapies, and some opt to discontinue the treatment. Alternative or innovative treatments or long-acting drug delivery system would be required to offset the compromise between the treatment burden and visual outcomes by increasing the drug efficacy and durability of treatment response. Thank you.
Am I audible?
Yeah.
Yeah. Very nice presentation, Dr. Karthik. Just summarizing everything that we see in the treatment of neovascular AMD, the burdens over the patient or the healthcare system. Yes, as of now, the new drugs even we have are not enough or not sufficient to decrease the or increase the time interval or to maintain the vision of the patient. Even if you have the new drug, like we'll be discussing later on regarding prolozimab and about half an area by Dr. DBB. One thing that I would like to discuss about that nowadays, we are talking about the port site, PDS with the ranibizumab, the port delivery system. Yeah, still it is an under trial, and we have a data of phase 2 trial where the results are encouraging, and probably if you have these things after phase 3 trial, it may be a game changer for the future, because as of now, we do not have such facilities that detect the early recurrence of this disease. We follow the treat and extend regimen in our private practice, and it's not we are not able to follow patient regularly, like monthly visit. So in such scenario, in between, if there is a fluid increase, we do not have that much facility to just immediately give injection. So here, if we have such system, or if we have such drug which remains in the eye for a long time, like what we discussed about PDS or port delivery system, that might be a game changer in future. But as of now, the latest molecule that we have, prolozimab, Dr. Devendra will discuss about that, about the pros and cons of the new drugs.
So I'll invite Dr. Devendra to present his talk.
Thanks, Dr. Karthikeya. It's wonderful to be part of this session and part of this wonderful meet organized by Udaipur Ophthalmological Society. It reminds me of some of the journal club articles that we had to present during our production. So we jump into it. So Hawk and Harrier were basically phase 3 multi-center randomized double mask trials. And these are the types of trials that are required before any drug gets FDA approval for use. So these were two parallelly conducted trials. And I always start by congratulating Novartis on the choice of the names, because Hawk and Harrier are types of birds of prey with very, very good vision. So we are hoping and expecting that all our patients will also get back such excellent levels of vision by using this molecule. Basically, as an introduction, this molecule is the smallest functional unit of an antibody, which is called a single chain antibody fragment. And because it's such a small molecule itself, you can pack in more moles. It can have a very high molar dose delivery because you can pack in more molecules in the same volume. And it has better tissue penetration and longer duration of action is proposed because of its very small size and better penetration into the choroid. Now, these two trials are conducted around the world. Hawk was predominantly in the North and South America, Australia, and in Japan, whereas Harrier was in Europe and in Southeast Asia. What is important is that neither of these trials had sites in India. So we would be requiring to look at the Indian evidence or evidence of efficacy in the Indian population before we come to any conclusions. All these well-documented and well-planned RCTs would have very stringent inclusion criteria, and these were no surprise in these. Most of the patients had, we're talking about, of course, age-related macular degeneration with active CNV. And you can see that the visual acuity had to be between 78 and 23 ETDRS letters, inclusive of those. But patients were excluded if they had either they had been treated before with any investigational or approved treatment. So these had to be treatment naive eyes. So let's remember that when we extrapolate these findings to our populations. And also they should not have had any prior inflammation or infection in the eye under question. So there were various time points in the studies which were called disease activity assessment visits, and these were at week 16, weeks 20, 32, and 44, and subsequently weeks 56, 68, 80, and 92. So here there were different criteria that were assessed, and based on these criteria, the management or the subsequent follow-up visits changed. Before we go to that, this is the consort diagram for Hawk and Harrier, which just encompasses or summarizes all the number of patients who were randomized. In Hawk, it's important to notice that there are 3 arms, brolucizumab 3 mg and 6 mg and aflibercept 2 mg, whereas in Harrier there are only 2 arms, the brolucizumab 6 mg and aflibercept 2 mg. Now these were the visits and these were the study injections planned. In both the arms, or in both the brolucizumab and the aflibercept arms, the first 3 visits, that was week 0, 4, and 8, they received the 3 loading doses. Subsequently, they were examined at week 16, and in the brolucizumab arm, only if they were found to have active disease were they given an injection, and then subsequently they were injected at 8 weekly regimens, 8 weekly intervals. Whereas if there was no disease activity at week 16, they then re-examined the patient at week 20 and gave the injection at week 20. And subsequently, as per the protocol. Whereas in aflibercept arm, after the 3 loading doses, they received injections every 8 weeks. And this is an important point, that every patient who at the disease activity assessment visit was found to have active disease, then received an injection in that visit and was shifted over from a 12-weekly dosing regimen to an 8-weekly dosing regimen. So if a patient was shifted over from 12 weekly to a more frequent 8 weekly regimen, then he stuck to that 8 weekly regimen irrespective of the disease activity subsequently in the course of the study. So this is an important proportion of patients who probably had more active disease, and we would like to know what were their outcomes versus the others who could be managed at a 12 weekly dosing regimen. So this was the data for Hawk and this was for Harrier. Now looking at the baseline characteristics, this is just a table to show that all of the study groups were comparable and there were really no confounding variables that were irregularly distributed. The primary endpoint was predefined as non-inferiority to aflibercept, which meant that the mean BCVA change from baseline to week 48 had to be within 4 letters. There were various secondary endpoints. We'll come to them when we talk about the results of the trial. So let's see the primary endpoint, that is the mean change in BCVA. You can see that at the end of week 52 and week 96, this is actually at the end of 2 years, you can see that the difference between brolucizumab and aflibercept is to the order of 0.3 to 0.5. So well within the 4-letter defined range. And here it's 0.4 in Harrier. So the study definitely showed that brolucizumab was non-inferior to aflibercept in terms of change in the BCVA from baseline to the end of first year as well as second year. Now the secondary outcomes, this was the proportion of patients who gained more than 15 letters from baseline. And here you can see that they were comparable amongst the two groups, with brolucizumab doing better. About 1/3 of patients gained more than 15 letters in who received brolucizumab compared to about 1/4 who received aflibercept. Whereas in the Harrier trial, it was roughly the same between the two groups. Looking at the OCT reduction in central subfield thickness, you can see that the green graph shows aflibercept data. And typically, as we saw in the View 1 and View 2 trials of aflibercept in AMD, you can see that sawtooth pattern where between the two doses, the edema increases. And once you re-inject at the subsequent visit, the edema is less. Whereas the brolucizumab arms showed much flatter and much more stable central subfield thicknesses at each time point, suggesting a better drying effect. But let's see the drying effect in a little more detail. Looking at the proportion of patients with intraretinal and or subretinal fluid at these various time points, you can see that brolucizumab patients had proportionately less intra or subretinal fluid. So this goes to show that brolucizumab does have a better drying effect. Let us divide intraretinal and subretinal and look at them separately. Here there is not much difference between the intraretinal fluid in amongst the two drugs. Whereas if you look at the subretinal fluid, you can really see a difference between the patients who received brolucizumab and those who received aflibercept. Let's look at even beyond into the sub-RPE space. Sub-RPE fluid was found to be significantly less common in patients who received brolucizumab than aflibercept. So if you recall, when View 1 and View 2 came out, we talked a lot about how aflibercept can even target the sub-RPE level or the PEDs and flatten PEDs. Brolucizumab appears to be doing even a better job than aflibercept at targeting the PEDs. This was what we talked about earlier, the disease activity status at week 16. So about 1/4 of patients who received brolucizumab had active disease at week 16 versus 1/3 of patients who received aflibercept. So this was a significant difference between the two arms. So it means that after 3 loading doses, a patient is more likely to have inactive disease if he had received brolucizumab than if he had received aflibercept. Now, what is interesting to note is that the proportion of patients who could be maintained on a 12-weekly dosing regimen at the end of the first year, it was more than half. So more than half of the patients who started off with the 3 loading doses could then subsequently be given only 3 injections of brolucizumab. So that is 6 injections in the first 1 year, which is very good in terms of the first year of treatment. So that's a very heartening sign, and it should hopefully translate into better patient satisfaction with treatment. And into the second year, about 3/4 of these patients could be again continued on a 12-weekly dosing regimen. So if you had completed the first year with only 6 injections, you are more likely to finish the second year also with only 4 injections in the second year. So 10 injections in the first 24 months, which is very good indeed. I think everybody is very interested or concerned about the adverse events, and looking at the Hawk and Harrier data, there were adverse events, no doubt, but they were not statistically significant between aflibercept and brolucizumab. There were instances of retinal artery thrombosis, retinal artery occlusion, but there were just 1 case in Hawk and 1 case in Harrier. So they were very, very rare indeed, and definitely not statistically significant at any rate. So just to summarize, brolucizumab was non-inferior to aflibercept with regard to the primary outcome, but was change in BCVA at week 48. The BCVA that was achieved by brolucizumab at week 48 could well be maintained till the end of the second year. Both trials showed that fewer patients had fluid in the intraretinal or subretinal or sub-RPE space compared to aflibercept, and there was better OCT central subfield reduction achieved with brolucizumab. So with that quick run through of the two trials, I'll just share one patient of mine who I've been treating since last 6 to 7 months with brolucizumab. He was a 68-year-old. He is a 68-year-old gentleman who first came to me in May last year, and he had already been diagnosed to have CNVM in the right eye and left eye had dry AMD. So this was the visit when we saw him, and you can see in the right eye large PED with subretinal fluid, multiple PEDs in fact, and he had already received one ranibizumab before, so we injected the second ranibizumab, and that was the visual acuity at that point in time. So again, when he came back in July, you can see that the right eye has some amount of fluid still persisting, so he received the third ranibizumab, and the left eye was totally in a dry stage even at this visit. There was a gap because of COVID infection in the family, during which time the patient could not come for follow-up. When he did come in September after 2 months, he complained of a drop in the vision in the left eye also. And you can see that the left eye also has now developed large PEDs with subretinal fluid. But the patient was more concerned about treating the right eye, and he said he wanted to wait for treatment for the left eye. And he received a 4th injection of ranibizumab in the right eye. And a month later, you can see that this is the subretinal gliosis that's developing in the right eye and large PED in the left eye. At which point in time, he was convinced of treatment for the left eye. And then I offered him the option of treating him with brolucizumab, which had just come out, because you can see these large PEDs, and the left eye being a treatment naive eye, I thought this was an ideal situation where we could start with a new drug, a new molecule for the left eye. However, the patient wanted to continue with ranibizumab in the right eye because he felt he was doing well with ranibizumab. So he said that I'd like to have ranibizumab in the right eye and brolucizumab in the left eye. So I was happy to allow that, because I thought it would be interesting to see in vivo 2 different eyes of the same patient being treated by 2 different drugs. And then probably we would, at the end of treatment, have some opportunity to compare the two drugs within the same patient. So we were all concerned in the initial period about the adverse events of vasculitis, etc. So I called the patient 2 days back after injection and did a large montage image of his fundus just to document and make sure that there was no adverse event of vasculitis or any such problem. He did improve in both the eyes, and you can see now at this visit, he was advised a 6th ranibizumab in the right eye and a 2nd brolucizumab in the left eye, because although there was significant drying in the left eye, I did tell him we are going to give you 3 loading doses and then only take a call after that. So just to quickly run through, he did receive the 2nd brolucizumab and the 3rd brolucizumab in the left eye. So when he came back in January, both eyes were quiet. The CNVM was quiet. So since he had received 3 loading doses of brolucizumab in the left eye, I said, we'll take a break and we'll see you after a month. So this was essentially the 1 month in which he didn't receive any treatment. However, 2 months after the loading dose, the left eye did show signs of activity, unfortunately. So he did have to take the 4th brolucizumab in the left eye with a very short interval, and the right eye received ranibizumab, the 8th injection. So these are just some Optus photos showing that the retina otherwise is very healthy and there have been no untoward reactions. He in fact came back to me today, just this morning, and he now had activity in the right eye, which was being treated by ranibizumab, and the left eye, which had been treated with brolucizumab, was quiet. Now the patient himself offered and said that since the left eye is appearing to do better, can we take brolucizumab in the right eye as well? So today I injected the first dose of brolucizumab after 8 or 9 ranibizumab in the right eye, and of course the left eye being quiet, I've advised observation. So I'll end my presentation over there. I'm sure we'll have a lot of points to discuss after this. And I'm sure we can all share some valuable inputs on these cases.
Very nice presentation, Dr. Devendra. Dr. Ankit, you would like to add something?
Yeah.
Any comments from your side?
The Hawk and Harriet trial, they have given us a lot of insight, as Dr. Devendra told us. And definitely in Indian scenario where the costs of treatment are very high, insurance companies do not patch up with the client, most of them, and also in government setups, because the bevacizumab is not approved, many of the government setups are not using it. So that is also causing a burden on the patient. And then coming to the dosing regimen, the dosing regimen is quite I would say, oriented to our requirements. because if the duration increases, as we see in the trials, as the duration increases, the cost comes down, the overall patient travel and the associated logistics will go down. So that helps to an overall reduction in the burden. So that would be my take for right now.
Dr. Arvind, you want to add something?
Yeah, very well explained the Hawk and Harrier, sir. But as Dr. Karthikeya said, like randomized controlled trials and the real world experience definitely are very different scenarios, and how this will be translated into real world is a little different, because it was after the FDA approval and then the adverse event started coming out, and it was the ASCRS paper that created a fear or phobia among the retina specialists to go about with this injection. So maybe let's see how this real world situation will be tackled, and the dosing regimen and all. Actually, it is like as the Hawk and Harrier says, a preloading dose and then go for the quarterly or 12 weekly or 8 weekly according to the response. But will this translate into the Indian scenarios? Because like with this event of OI, they say that the patients has to be screened, and you cannot go with all patients with the same regimen as with aflibercept or ranibizumab. So there should be some like screening for the patients also, who has to go for Peganex and then who has to go for other anti-VEGF. Maybe after the second discussion, we can think about, discuss on that, sir.
Dr. Rohit, you want to add something?
Yeah. Dr. Devendra, your presentation reminds me the our general club at LVP, and I would like to ask you one thing, that like in your case of brolucizumab, patient was not treatment naive, you already treated with ranibizumab, and then you shifted to brolucizumab. But if you talk about Hawk and Harrier trial, all eyes are like treatment naive eyes. So, I mean, how do you take these things in your practice, or what do you tell your patient that how it's going to improve the vision, or whether it's going to, worse? Because, much, naive, then you have a lot of options. But once it is complicated and then you shift, then I don't think so. The outcome is, that better as compared to treatment naive, which the Hawk and Harrier says. So,
yeah, you're absolutely right. This the eye which I started treatment with was treatment naive. That the left eye had not been treated with anything.
Okay.
So, which is why I told him that we'll even go for the 3 loading doses. And being a very compliant and responsible patient, I would say he understood that and he agreed to that. A lot of patients are a little apprehensive, especially when you tell them that 3 injections or फिर उसके बाद देखेंगे. So that always sort of confounds the entire issue. But being a treatment naive eye, as well as understanding the problem, he agreed to go in for treatment with 3 loading doses. It was the other eye which had been treated with ranibizumab, which then he sort of lost patience with, and he said, "I'm taking ranibizumab almost every month. So can we now shift over?" So this is again now in vivo and different aspect, that how is the eye now, having been treated with 8 ranibizumab, going to respond to brolucizumab?
Yeah. And how brolucizumab injection?
Sorry, I didn't get that.
How do you follow up your patient post injection?
So I was calling him back 2 days after the brolucizumab. So because he required bilateral treatment, what I would do is I would inject the brolucizumab on the same day and then call him back for the second eye treatment on the 2 days later. And at that time, I would take the opportunity to examine the brolucizumab eye to make sure that there was no adverse event. So now the reports are variable. I'm sure we can discuss that later. But the reports talk about intraocular inflammation at very, very variable and even much delayed time points. So there are going to be patients who may present with intraocular inflammation months after the injection. But I think as part of our responsibility to look for any damage, we should look for complications even as early as 2 days or 3 days after the injection. So he's aware of all these problems. So when I started treatment, I'm sure others who have treated patients with brolucizumab will also agree that we gave them a little bit of a questionnaire and said that in case you do have these symptoms, you need to come back, which is tenderness, redness of around, mimicking a circumcorneal congestion, floaters, drop in the vision. So any of these warning signs, you need to come back. So this is drilled into them, unlike if we inject Avastin, or Accentrix. There is just a vague sort of thing. If you have a problem, come back. But these were specifically told to them that they need to follow up if they have these problems.
Okay.
So what was the gap between the two injections of brolucizumab? Did you keep it the same for both the eyes, or?
No, the right eye has received only one. And so the left eye, I gave him 3 monthly loading doses, as like Hawk and Harrier. And 2 months after that, he unfortunately required, unlike Hawk and Harrier, 50% of them didn't require that injection at the 16-week visit, whereas he falls in that 50% who still has disease activity after the 3 loading doses, 2 months after. So for 1 month he was fine, and then after 2 months he developed recurrence. So let's see how the left eye pans out over a period of time.
And have you injected in any one-eyed patient?
I have, yes, I have. I have those slides. In fact, I have those slides. She is an 80-year-old woman who had lost one eye to CNVM. And this eye has now developed a CNVM, and I've injected 3, and she's doing very well. She's doing very well.
So, any role of autoimmune disease, like a patient suffering from autoimmune disease, and then ruling out, like you're keeping exclusion criteria for those patients?
I think, we can cast a very wide net of exclusion criteria, but somewhere down the line, it's going to be impractical, because, we even thought of initially I excluded patients who I anticipated will require intraocular surgery, like a cataract surgery. If they have an NS1 or 2, and I think, okay, within a few months, 6 months, you may require cataract surgery, then I would rather avoid brolucizumab. But then where do you end? Because the most of the patients are like this. And the second thing is that personally, if you ask me, the incidence of this complication is exceedingly rare. And if you're able to pick it up, I don't think it should be so dangerous as one thinks it may be.
Okay, so we would like to have we'd like to invite Dr. Anshu Arora. Sir, we had given you a brief introduction when you had not joined us. Sir will be speaking on his initial experience with brolucizumab. I welcome you, sir.
So basically, can you hear me?
Yeah.
Yes, sir. Yes, sir.
Yeah, I'll just share my screen once. Is my screen visible? Presentation?
Yeah.
Okay, so as I usually tell my patients, AMD is a disease in which you need a constant treatment. It's unlike diabetes, which resolves with certain amount of drugs going inside the eye. But then in AMD, you do get these recurrences most of the time. So there was an unmet need for a drug which requires lesser dosing and is at the same time very effective. So when brolucizumab came in, I heard a lot about the risk involved also, but then I said it is worth a try, and I went ahead with a few of patients of mine with this drug. And in summary, I have these 5 patients whom I have injected 8 intravitreal injections of brolucizumab. Out of these, four patients were earlier treated with ranibizumab or aflibercept and had residual fluid of intra or subretinal or both kind of fluid were there. There were 3 patients out of these 4 who had recalcitrant intraretinal subretinal fluid, which was and had undergone multiple anti-VEGF in past. They in fact showed very encouraging response to brolucizumab. Encouraged by this, I kind of counseled 2 naive patients and 1 I have treated recently. And 1 patient out of these, all patients have completed their 3 loading dose of intravitreal brolucizumab and is now due for the extending dose in April. He's maintaining no intraretinal or subretinal fluid over more than 10 weeks now. And fortunately for me, there was no adverse event and with first or subsequent dosage of the drug. So I'm sharing a few of my cases. This is the first case, which was a 72-year-old male. He had a diagnosis of wet AMD in both eyes. Right eye had central macular scarring with vision of 2/60, so he was practically one-eyed. And his left eye had active CNVM with intraretinal and subretinal fluid with an extrafoveal PED SHREM of a classic finding of a long-standing AMD. He was under treatment since February 2018, and he had received 3 loading doses followed by PRN ranibizumab, a total of 16 number of injections. He presented in October 2020 with drop in the left eye vision to 6/36. So this was the initial presentation when he came in 2018 and with 6/12 vision. And then with multiple doses and maintenance dose of PRN ranibizumab, he was maintaining somewhere around 6/12 to 6/18. But when he came back in October after because of the lockdown, he came back with a drop of the vision to 6/36 with PED, SHREM, and intraretinal fluid increased in the left eye. So this is after his loading dose of brolucizumab. That is, this is the patient who received 3 loading doses of brolucizumab. He had, practically dry retina, and he had this PED persisting, and he had a best corrected visual acuity of 624. I've been following him since last about 10 weeks, and he's doing pretty well. There is no recurrence of fluid, but still I'm encouraging him to go for another dose after 12 weeks. The second case is a switch from aflibercept. This lady is a 59-year-old female who presented in August with 2 days history of metamorphopsia and drop in vision in the left eye. She had right eye vision of 6/6, left eye 6/18, and she had received aflibercept in August, September, and October. She was switched to intravitreal brolucizumab in December 2020. So this is the initial presentation. She had in left eye, she had a large juxtafoveal, predominantly classic with some occult component here, and had received 3 doses of aflibercept in August, September, and October, as I said. This is the picture after her 3 doses of aflibercept, and subsequently when I gave her brolucizumab in December. This is the picture which I captured in mostly end of February, I guess. So this is the last time she visited me in the end of February. So she's due for her recheck in March end, and for her extension next dose on March 30th. This is the third case, which is again switched to brolucizumab. She's a 78-year-old, very old patient of mine, very sweet lady. She comes very religiously for her follow-ups, and she had received ranibizumab and biosimilar in past on PRN basis, 14 injections. She had recurrence of edema. There were fluctuations of her vision, seesaw effect of her vision, and that the vision was constantly deteriorating from 6/9 to 6/24 over the years, in spite of treating her on PRN basis. She was not available for review during lockdown. She's a lady who lives alone and not able to, come alone. And she always came with a driver who was not able to come on this lockdown period. So she came back with a poor, complaint of poor visual acuity, and came back with vision of 6/36 recently. So this is the picture of pre-lockdown after 14 injections of intravitreal ranibizumab or biosimilar. You can see these intraretinal cystic spaces, and there was no, though there was no subretinal fluid, but this is kind of degenerative kind of fluid which they over time accumulate. If it is an exudative fluid, it responds well to most of the anti-VEGF but this degenerative intraretinal fluid, they are very resistant to, resolve totally. So this is when she came back after the lockdown and post brolucizumab. This is 3 weeks post brolucizumab. Her vision was back to 618, and she still has some intraretinal fluid, which is probably the degenerative kind, which is going to take its own sweet time. But definitely, the effect was much better than after 14 doses of ranibizumab. I never had this kind of minimal intraretinal fluid as compared to others. In comparative terms, it is minimal in her ever. So all these patients, when my plan A with aflibercept or Eccentrix or Avastin didn't work, I thought plan B is a valid option. Coming to the patient who was treatment naive, he is a 48-year-old young gentleman with pachychoroid PCV. And he presented with 618 vision in right eye, which was elsewhere treated with anti-VEGFs. And he presented with left eye subretinal hemorrhage with vision dropping from 6/9 to 6/36. And he was very, very tensed because he had this experience with the other eye. He works in an IT company. So he was, very disturbed with the fact that this eye is going to get the same end result as the other eye. So I offered him to be treated with brolucizumab, encouraged with the result which I had with the earlier patients. So he came back with 1 month post-injection vision of 6/9, and he's extremely happy. He said, why I didn't have this injection when he was getting treated with the other eye. So with my experience, it's a drug with good response, even in chronic wet AMDs. It's a viable alternative in recalcitrant cases. And the best part is you can work out on 12 weekly spacing with this drug, which was in fact the best spacing we could imagine with treat and extend. And this is what we were aiming with treat and extend, and this drug is offering us this extension of treatment with even just after the first loading doses, 3 loading dose injections. Thank you.
Thank you, Dr. Anshu. It was a very nice presentation. Dr. Devendra, you would like to add something?
Yeah, I think Dr. Anshu, very nice cases, and you brought out the point that predominantly we can use this drug in 2 types of patients. One is the treatment naive patients, and the other is the recalcitrant patients. And I'm sure we are going to get good results with both. Now, where I feel evidence is lacking is that when aflibercept came out, everybody said, "Oh, 8 weekly." And unfortunately, aflibercept didn't live up to that reputation of being required only 8 weekly. Similarly, whether it's aflibercept also, our experience has been that 8 weekly is probably a small minority of patients who do well, whereas most patients require monthly or 6 weekly or something like that. So it remains to be seen with brolucizumab that can we really replicate this 50% of patients who required only 6 injections in the first year with brolucizumab in the real world situation. So I think that is going to be the holy grail, and if that's possible, then I think it's a great trade-off because the drug is competitively priced. So the pricing also plays an important role in the patient's mind. If you have that, if you can demonstrate to them that over a period of time you're likely to require only these many injections, then I think the uptake will be better and the patients will benefit more.
Yeah, I just
actually, you have to, excuse me, you have to stop sharing your screen.
Okay, just one second.
So that we can see all the...
I lost that.
Yeah. Yes, sir.
Will it stop now? Right.
Yeah, yes.
So I was saying that, most of the AMD patients which are treated with PRN, I've seen over the years that they tend to deteriorate. And, the treat and extend is the best way to treat these patients. So this is, in fact, a very good drug which helps us, space out the injection. The only question which I asked which is unanswered to me is, if we go treat and extend with brolucizumab, how can we do that? It cannot be an endless process. So we can look at extending the treatment with brolucizumab also, which I believe even the Hawken Horrier doesn't answer that at present, because they gave 3 monthly all the way. So everybody should follow treat and extend rather than telling that 3 injections and then we'll see what has to be done, or treat PRN, because in the end, if you see all major studies, the PRN treated patients, they don't do as well as treat and extend.
Yeah, no, that agreed. But I think the importance of loading dose should also be stressed, because real world data also suggests that from the Luminous trial, for example, that if you are able to get those 3 loading doses initially, especially for a treatment naive eye. Now, it doesn't make sense when you've already treated with 7 injections of Avastin or 10 injections of something else, because at least the theory is that your VEGF load in the eye has already been reduced by multiple prior injections. Now, in a treatment naive eye, that's not the case. So I think if you hammer it in hard initially, your long-term results are going to be better. Then you switch over to treat and extend or PRN or whichever else one is comfortable with.
Yeah, another point which I wanted to raise is regarding the adverse reactions, because they report that in all the anti-VEGF, this particular one has more incidence of intraocular inflammation and all. And a recent article in Journal of Clinical Medicine by Boston, Massachusetts, published in March only. So they have said that the sterile intraocular inflammation and the brolucizumab associated retinal vasculitis, it is higher as compared to the others. And they were contemplating that it may be because of the presence of antibodies, pre-existing antibodies towards this particular molecule. They also said that it could be because of the presence of an underlying cardiological problem, cardiovascular problem in the patient, which can be more in towards the vasculitis side. And another thing which I was thinking, that because the molecular size is small, the dose content has more molecules as compared to the others. So could this be a reason that could be causing more inflammation compared to the other molecules?
The inflammation which has been noted in the patients are very variable. There are patients who have not shown inflammation in initial first week. They have shown inflammation in 3rd week also, which is probably indicates that it is a type of immune response which you are getting. And apart from that, if you see, even read the fine print, the drug has almost 4 times the chances of adverse event happening as compared to your earlier ranibizumab molecule. Probably this is yet to be discovered, whether it's because when even the the biosimilars came, you had some issues with inflammation, but that was more related to the carrier of the drug rather than drug itself. And in India, what I last learned with the representatives, that out of 1,500 drug injections which have been given so far, there are 10 reported adverse events, which out of that almost 8 or 9 of them resolved. They were simple flares and they resolved with the topical steroids itself. Only one patient, which Dr. Raja from Hyderabad has reported, had a very severe inflammation, but that patient too, after vitrectomy, had not shown any kind of vasculitis. So it is it is definitely one should tread carefully and avoid in patients who have history of inflammation like uveitis, or have undergone a recent surgery, or are one-eyed patients. These are the patients I would not go in for trying this injection out, but definitely for my patients who've been receiving a lot of injections earlier and our treat and extend, this is a very good alternative for
them. So as we all know that cost is a big issue in India, basically in small cities like in Udaipur. As I'm practicing, still I give a lot of patients, I treat a lot of patients with Avastin. because it is it is comparatively quite cheaper for all the patients. So do you feel that we should emphasize on it being used as a first choice drug, or we can still use it as a drug which can be used once patients have stopped responding to Avastin or are not responding to ranibizumab, or then we can shift to bortezomib? Or we should, does it sounds that promising that we should use it as a first mode of drug?
No, I think that's the $1 million question. I mean, that is literally and figuratively. The reason being that if you look at CAT and IMAN, if you're prepared to treat a patient monthly with Avastin, you'll do as well as PRN ranibizumab. So you have to compromise somewhere. Either you increase the number of visits and increase the number of injections with Avastin, and you will get roughly equivalent results as is if you treat with ranibizumab on a PRN basis. Now, we don't know about brolucizumab. There is obviously no head-to-head trial that has been done. But I think the disease burden financially is more of a problem for many patients than is the actual vision loss. So I know we have to prioritize, and I'm not in a very posh area of Mumbai, so I would say most of my patients also end up receiving Avastin. So it is definitely, I think something is better than nothing, and the more you treat, the better it is.
But if we tell the patient regarding the adverse event, the patient should be informed prior to that there are reports regarding the vision-threatening vasculitis, which is a possibility. So if we give an option to them, then definitely patient would go for a safer drug than this. So will that not hinder the
No, I think it all depends on how you put it and how convinced or how not convinced you are. Because I mean, who's to say that cluster endophthalmitis does not occur with Avastin? So you always have a risk, and at the end of the day, you have to make the patient aware of the risk. But at the same time, the risk awareness should not interfere with the actual treatment, right? So there has to be some compromise.
I have actually, after speaking to a lot of patients about this drug, I have in fact drafted my own consent of patient X, and I explain them about the chances of inflammation. I tell them that this drug might have 4 times more chances of causing problem to you than the other drug, and you have to leave it to the patient. So most of the patients who have treated, as you know, they were already getting treated. So they said, okay, so if I'm losing vision by any way, and if if you believe that the drug is going to work well, let's try it. So it depends on depends on the confidence the patient has on you.
Maybe the chronicity of the patient. Even if the chronic patient, yes, they will convert very easily.
And as far as the cost factor is concerned, I believe you should offer your patients the best drug. If they are, if they can't afford, then give them an option. There's no harm in treating them with any drug rather than not treating them. So it's important to tell the patient. Sometimes patient surprises you that what, my sight is more important than what money matters to me. And you believe that this patient will probably be going for ranibizumab or something like that, but he tells that is there something better drug which you can offer me? So definitely it differs with the places, and but you should offer your patient the best choice.
Yeah, especially, I mean, the early disease is easier to treat. I mean, nAMD is as simple. Obviously, if you treat before he gets scarring, you're going to be able to preserve his functional vision much better. So at the end of the day, it doesn't matter which molecule you treat, but earlier and the more aggressively you treat.
True, very true.
I do have one of my close connects that he's now around 58, 59 of age, and we have given 41 injections till now. So the last 7 injections have been Eylea in almost around 18 months. And previously she was constantly on either Lucentis or then shifted to Eccentrix. And then we shifted to Eylea, and she is maintaining 6.9. Since 2013, she is maintaining 6.9.
So that's the proof. You keep treating and they'll maintain. But AMD is age related, so there's no end point. As you age, the disease is only going to get worse. You have to
see what I tell my patients when I explain them, when they ask, okay, how many injections are we going to receive? They go to n number of ophthalmologists sometime, and then they can come for a second opinion to you. At times, what happens is, they are convinced that the other ophthalmologist has told 3 is going to be the end point for you. So that makes your job difficult. But I remain very honest with my patient. I said 3 is not the end point for you with me. It is going to be longer, because I tell them, it's like the AMD is like a road which has this beginning and this end. Okay, so this end is definitive. That is, the atrophy or scarring is going to be there with the disease. The only thing is how slow we can make the disease progress to that end point. So that is how I tell my patients, like, we create kind of speed. We are creating a speed breakers on the way to your deterioration, so that you deteriorate slow. And most of the patients who religiously follow the follow-ups and they religiously get treated on priority according to their visual requirements, then they usually do well. Only the patients who are convinced that 3 is going to be the end, those are the patients who end up with loss of vision.
I think the worst are the patients who have been treated with 1 injection and they have not been told that they require multiple injections. And they come back 6 months later with nice, beautiful scars, disciform scars, and then you as a retina specialist is now supposed to treat those scars, when all you can do is refer the patient for low vision devices.
I know you sometimes get these patients coming from anterior segment surgeons also, who would try this drug. Say, there was a guy who used to see me how I inject, and after some time he said, why not, let's try that, it's no big deal. And after a few months he started sending me patients that this guy is not doing so well with the injection. So I said, what was the schedule which you were following? He said, I was giving, whenever he used to come, like any 3 months or 4 months, he used to come and he used to inject. So I said, it only benefited you, it's not going to benefit the patient. So it should be treated properly.
Yeah, you took the words out of my mouth.
That's true, because half-baked knowledge is more dangerous, both for the patient and for the anti-segment surgeon. Both of them.
Sure.
And just to put another perspective, when we talk about brolucizumab, again, we are having to restrict ourselves to neovascular AMD, because unlike the other anti-VEGFs where you could give for DME, BRVO, CRVO, even uveitic CME, here these are almost contraindications for brolucizumab. So we're looking at a specific indication, and even within that we have a lot of exclusion criteria. So it's important to remember that.
The best part I see about this drug is it dries up the intraretinal fluid very well. Subretinal fluid is sometimes unforgiving. If it is there, you don't mind a little bit of subretinal fluid in certain cases, and it remains there at times. But intraretinal fluid is bad. Actually, you need to dry up the intraretinal fluid, which is done pretty well with this drug.
I would say the take which we can take from today's talk and all what we are reading and seeing the patients is, it's a molecule in a very early stage and giving you a high risk but a high return. So as the time will pass on, we will come to know what is the actual risk over a period of months and next following 1 or 2 years. And definitely the returns are good, the results are good. So I hope the incidence of problems will come down, especially on the both the cost side and towards the side effects.
I think we, at the end, we need to understand that we need to treat and extend. That's the main point. Whatever injections we are using, drugs will keep coming, and whatever best suits to the patient, his pocket as well as his eye, both need to be considered and then decided what we need to inject for the patient. So it was a very nice discussion. Dr. Arvind, Dr. Ankit, anything else you want to add, or we can sum up the meeting? Anything else?
last few words from Dr. Devendra and we can sum up.
Yeah, that will be nice. Dr. Rohit has lost the contact. Dr. Devendra sir, any take-home message from your side?
No, I think we summarized it quite well, and it was a lovely discussion. I'm really happy to have participated in it, and I'm sure we'll all benefit from it. Let's see how things pan out, and it's early days for brolucizumab. It's still a new kid on the block, so let's hope that we have something that can actually help us and help our patients.
Thank you, sir. Dr. Anshu, you want to add anything?
Nothing more. It was pleasure meeting you all on the web, and I believe keep the fear aside. It's a good drug, and the patients who can afford it, and the patients who you feel that are responding suboptimally to other drugs, it's a very good alternative to those patients. As far as naive is concerned, I'm still myself naive to that fact, and I'm trying out in the second patient now. And the first patient has given me encouraging results.
Thank you, sir. Thank you. With that, I'll thank you all for participating in this webinar and making it so fruitful for all of us. Thank you very much. And I wish all of you a very, very happy Holi. Thank you, sir.
Thank you. Thank you all, and happy Holi.
Good night.
Thank you. Thank you.
Good night. Good night.
Good night.
Good night.